At a booking visit, first time mother is told she is Rhesus negative. What is the best advice you want to give to that mother? Anti-D will stop your body creating antibodies to your baby's blood that will help to protect the health of your next child. That is what you will basically advise. What is the other option you want to try? Why not D? There are some big marital problems that will arise if you do D. If your partner is Rhesus negative, you do not need to have anti-D. If you say that and test her partner, right? There is some review available for you about the D. Option D. Where is option? If a woman's partner is Rhesus negative, she is Rhesus negative, ideally child should be Rhesus negative. However, it is possible that 1 in 10 partners may not be real father. She might have gone to a Sepsis scandal Swamiji for getting the boon of becoming pregnant, and Swamiji turned out to be Rhesus positive, then problems arise. So don't let things enter into a wrong note unnecessarily. That's the point. Okay, unnecessarily. So one of my nephew, he went to do MS computer science in US. He and his friends were all, they came to Hyderabad, they were traveling in outer ring road, they had an accident. So a couple of them had head injury, but out of the 6 guys, 2 were high accident. So all of them, I have suddenly shifted them to the tertiary center. All of them are from a very big time families. One of the guy was HIV negative. In this accident, because of the investigations being done, at that time it turned out to be HIV negative. Who was who went to do MS there, unfortunately. So accident ko bhul jao. There is a new problem that we need to handle. How to handle that? Because that one of that guy is a bit probably too light at his heart. So suddenly he went to US and he had got too much of freedom and ended up. So that way, sometimes what happens is, for some reason you will do the investigations and some things will come up. And that's the reason when it is not required, you need not do. Very commonly, if you do ultrasound in elderly people, aortic aneurysms will come out. What is the most common predisposing factor of aortic aneurysm? Atherosclerosis. Above 65, everybody will have slight dilatation of the aorta. Unless it is more than 6 centimeters, you need not worry about. Right? And similarly in women also, ultrasound will reveal lot of cysts in the ovary. All cysts in the ovary are not tumors, you need not do anything. So they are all incidental omas. So that is the story, doctor. 40-year-old diamniotic twin pregnancy at 31 weeks of gestation comes with painful pervaginal bleed of about 400 ml, and she is cardiovascularly stable, and she is having abdominal pain every 10 minutes, and there is a small active bleed on speculum, and both fetuses are having a reactive cardiotocography. She has no problems antenatally, and her 28-week revealed both placentas to be well away from the cervix. They are not in a placenta previa position. Then what is the management of her? Admit her to the labor ward, ABC, IV access, full blood count, cross match, CTG, steroids, consider expediting the delivery. Okay. So she is not in labor and both twins have got a normal CTG. It would be wrong to let the woman to go home is the most important thing. She need to be delivered urgently by cesarean section. And she should be admitted to the high risk area and as a part of initial assessment you should do the cardiovascular review. Now a 27-year-old nulliparous woman who is 36 weeks 5 days pregnant admitted with preeclampsia, and now she has thrown a seizure. So classically she is a case of eclampsia, potential eclampsia. Remember doctor, two common mistakes people do, common things. As a house surgeon, when you are entering casualty, you are about to take over the duty. Suddenly the bed number 4, bed number 5 or somewhere there is a seizures. What should be your first impulse to do? Anyway, you will give one anti-epileptic midazolam or something and then try to rescue. But very common thing, don't forget, is you should rule out hypoglycemia. Hypoglycemia is a very common cause of seizures in the intensive care unit and also in the casualty. Anyway, you give anti-epileptic, but also quickly check the blood glucose. When it is low, give 25% dextrose. That will help. So even in the case of the labor room or a obstetrical ward also, seizure means not always eclampsia. Seizure could also be due to a simple hypoglycemic episode, is what you need to remember. So this woman has an eclamptic fit and calling for help, lying the woman flat, tilting her onto the left are the first steps to prevent compression on the IVC, is what need to be remembered. 38-year-old, she is a case of SLE, renal stones and malaria. Her BP is 158/99. Her platelets are given 55,000 and her creatinine is increased. So what is the most likely diagnosis? You all know HELLP syndrome. Hemolysis, elevated liver enzymes with a low platelet count, which is typically a feature whenever there is any preeclampsia, is what need to be remembered. A 19-year-old first time pregnant comes to clinic with the lesions which are being shown on her labia. So what are these lesions, doctor? Herpes. So how do you manage herpes in a 33-week pregnant woman is the question. So if she labors within 6 weeks, a cesarean section is the one which is being recommended in this given scenario. Why not? What is B? Cesarean should be performed if she labors within the next 8 weeks, right? Why not B? Yeah, if she labors within 6 weeks is the protocol in case of primary herpes to consider for a cesarean. It all is the incubation period, etc., etc., and the response for the treatment. After you initiate treatment, how much time it will take to become non-infective. There is a lot of story in the management of a herpes in pregnancy. 33-year-old woman presents with 2 days history of itching of the soles and feet and palms. Her LFT shows ALT elevated, bile acids elevated. See doctor, 4 important conditions that lead to jaundice in pregnancy. You should not forget. Immediately after going home, open Datta and review differences. There is an entity called obstetric cholestasis. Why cholestasis? Pregnancy may progesterone will be high. That will slow down the all exocrine ductal movement. That lead to obstetric cholestasis. There is an acute fatty liver of pregnancy. Then PUP, pruritic papules and papules of pregnancy. Urticarial papules of pregnancy. PUP, pruritic urticarial papules of pregnancy. PUPP. Then hepatitis B by itself can lead to development of liver dysfunction. Then HELLP syndrome, you have got the elevated liver enzymes. So you should differentiate these 5. Out of these, which comes in first trimester, third trimester, and which will be recurring in the next pregnancy, which has a good and bad prognosis. All that 2 pages, doctor. Datta mein one question, inevitably every entrance you go, they will give one out of these 5 diagnoses, which you have to be very clear, right, doc? So, what is the advice that you need to basically give to her? So, obstetric cholestasis means there is an itching, deranged liver function, elevated bile acids. So, once you diagnose obstetric cholestasis, you have to check the LFT every weekly. The main challenge of obstetric cholestasis, one of the main complications is stillbirth. So, there is no way that you can predict the stillbirth. And preterm labor also is more likely. And meconium stained labor, staining in the labor. So, that's a thing. And how do you treat it? UDCA, obstetric cholestasis. Ursodeoxycholic acid is considered to be the management of choice. A 24-year-old, 32 weeks of pregnant, presents to the labor. She has stayed in bed because sunlight hurts her, and she had a macroprolactinoma. She is hemodynamically stable, and you have arranged a CT of her head as an emergency. No further information found, and red cells are there in lumbar puncture, but no organisms are isolated. What is the most likely diagnosis? And she has a terrible headache that has not improved in spite of analgesia, and it started 2 days ago and came on suddenly. Sunlight hurts her. Come on, migraine. There need not be history of the migraine in the past. Migraine first time may be diagnosed during pregnancy. That's the point. Anybody answered subarachnoid hemorrhage? Thunderclap headache is the name which was being given. Photosensitivity is not a feature of subarachnoid hemorrhage. But your lumbar puncture showing blood cells, na? Because some amateurish house surgeon tried a traumatic lumbar puncture. That's the reason. Blood cells in CSF in LP are not always indicative of subarachnoid hemorrhage. Yeah, so that's important. Now, doctor, 19-year-old, she typically has got past history of appendicectomy, large cone biopsy, palpable lower abdominal tendency, her WBC count elevated, her C-reactive protein is high, she has an offensive vaginal discharge. What else is required for you to diagnose a woman in sepsis? And if she is in sepsis, no indication for doing cesarean. Antibiotics and induced labor is considered to be the management, and tocolysis should never be given for a woman who is in sepsis. 24-year-old multiparous woman at 23 weeks pregnancy, she had a chicken pox before. She didn't have, but she got exposed to a baby who has got chicken pox. So what is you basically want to do? You test for the varicella antibodies and give varicella immunoglobulin within 10 days is considered to be the management. Yeah? Option B. B for boy? Okay, let's see what is B. Test for varicella antibodies and give varicella just immunoglobulin within the first 24 hours. What is varicella just immunoglobulin offering you? Passive immunity, right? There are certain recommendations. You said option what? B, no? Somewhere I mentioned in the literature about B. B, yeah. Just review the literature. There is a short explanation attached to that. Now, what are the contraindications for external cephalic version? Multiple pregnancy, APH and rupture of membranes. You cannot do external cephalic version of the baby. Is there any indication in the modern obstetrical practice for internal podalic version? Second twin in pregnancy ke liye, you will do internal podalic version. Otherwise, there is no indication. 24-year-old type 1 diabetes, she is on an insulin sliding scale. Under your review, her on the ward 12 hours post-operatively, and she has begun to eat and drink. So, how would you like to manage her insulin requirements? So, you change her back to the pre-pregnancy insulin, stop the sliding scale. Sliding scale is only for, sliding scale, right? Depending on the sugar levels, you will keep changing the glucose levels. Commonly done on the patients who are in-home, admitted inside the ICU. Even they also, once you get an idea how much they require insulin on average in about 2 to 3 days, you will go on a non-sliding way. 19-year-old preconception clinic, and she has SLE and wants to fall pregnant. What is not a risk of SLE to develop pregnancy? Preeclampsia, stillbirth, IUGR, they are all the risk factors in case of SLE women. 45-year-old, 18 weeks pregnant, presents 2-day history of viral illness. She has eaten soft cheese and she read on internet that is bad. So what is that transmitted in cheese, and that can be leading to abortions and stillbirths? Listeria monocytogenes is the one which is typically transmitted. It is not viral illness. It presents like viral illness, and she read on internet that what can present like viral illness which is not virus, right? See, your patients are very intelligent, doctor. They will come with they will tell you, American Cancer Society recommendations on the before week I had a judge in the High Court who is detected with CLL. So he has come to the OP and said, doctor, what is your opinion and take on the introduction of chemotherapy for me against in accordance with the American Oncology Society recommendations, and he took out a printout and gave me. I suddenly thought, बहुत जमाना हुआ, what is the current thing going on in the oncology recommendations? Judge साहब आप दे दीजिए, हम जरा पढ़ के हम भी पढ़ के आपको बताएंगे, because you wrongly recommend, he will hang you tomorrow. So he said, he kept his spectacles and he underlined some of the sentences in that printout. I thought ये तो तैयार है मुझे sue करने के लिए बोल के. Very nice man. And see, doctor, most benign of all leukemias is CLL. CLL is incidentally found if you do a peripheral smear in an elderly man. What do you see? Smudge cells, broken WBCs, which are mature looking WBCs. They are not blasts, unlike in case of CML or ALL, etc. ALL is in pediatric population. CML is a middle-aged man with a massive splenomegaly. CLL is the one which is typically found in elderly people, most benign form of all leukemias. Without treatment only, people will go to the graveyard, and if you dig the graveyards and do a postmortem biopsy, a lot of people will be found to have undiagnosed prostate malignancies and CLL if they would have died after 80. So beyond 80, they will have one or other internal malignancy that will arise. Because tumor surveillance mechanism, how many days the clock can run? It can't run, right? So that's the reason the time has come where if somebody blesses you long live for 100 years means very challenging. Up to 80 years is okay. So that is a better option. They say no, 26-year-old woman, 37 weeks pregnant, has got a rash and shown in the figure. Classical thing about rash is it is involving all other areas but not involving the periumbilical area. Periumbilically sparing nature of the rash is the characteristic feature of PUP. Pruritic urticarial papules of pregnancy. Okay, so that is the reason PUP is the diagnosis with the periumbilical sparing. Please review the literature given to you. How do you differentiate it from impetigo herpetiformis? Impetigo herpetiformis is not herpes. It looks like herpes that occur in the pregnancy. That's the point. Now, the remaining questions are a cakewalk. Let's quickly run through. Subdural empyema, most common organism is Streptococcus pneumoniae. What is an empyema, doctor? Empyema is the pus in the, come on, pus in the, where? Is it in the lung or in pleural cavity? Come on, doctor. Huh? Pleural cavity. How do you identify radiologically? It will be a fusiform opacity. If the abscess is there in the lung, lung abscess you call, which will be more globular opacity on radiology. Go to anatomy2medicine.com. In that you are having the extensive video library on radiology. Review the pulmonary radiology topic in that. You have got all this explained there. What is the treatment if it is empyema? Put an intercostal drainage tube and drain the pus. And if it is lung abscess, you can't put a ICD. So you have to give 6 weeks antibiotics. That is the treatment. Okay. So, subdural empyema, Streptococcus pneumoniae. 76-year-old with a history of frequent falls and difficulty looking downwards and laterally. Typically is an example of classical of supranuclear palsy. See, doctor, 4 conditions are called Parkinson plus syndromes. Parkinsonism has what is the classical triad? Echinacea, rigidity and tremor. What type of tremor in Parkinsonism? A symmetrical tremor. If the tremor is symmetrical, it is not Parkinsonian tremor. In every Parkinson's patient, you should always test him for dementia, because there are a lot of conditions which involve basal ganglia and also lead to development of Parkinsonism, which are called Parkinson plus syndromes. So you have got temporal lobe dementia, right? Then supranuclear palsy, right? Then you are having autonomic dysfunction in Parkinsonism. What is that called? Come on. Autonomic dysfunction with Parkinsonism. You didn't hear of Steele-Richardson syndrome. Okay. So these are all called Parkinsonism plus syndromes. So where is the center for conjugate gaze? Where is the center for vertical gaze in our brainstem? Who will give me the answer? Conjugate gaze ante enti, doctor? If you are looking to your left eye abducts, right eye adducts. What is that called? Conjugate gaze. For the adduction to happen in the right eye, what is required? Oculomotor nerve. For the abduction of your left eye, whenever you are looking to the left, your left eye's abducens. Actually, I should draw like this. Right eye's oculomotor and left eye's abducens must coordinate with each other. So what is brainstem? Medulla, pons, midbrain. What are the 2 cranial nuclei you have in midbrain? 3rd and 4th. 5, 6, 7 you have it in pons. 8, 9, 10 everything else is there in medulla. So what is that pathway that connects oculomotor with the contralateral abducens? It is called medial longitudinal fasciculus. If this has a lesion, what will happen? When this eye is abducting, the other eye has no information that the opposite eye is abducting. So this eye fails to adduct. When the other eye is abducting, this eye should get information. But if the middle longitudinal fasciculus is abnormal, when one eye is abducting, the other eye doesn't adduct same time for a conjugate gaze, then what will happen? Right eye is looking straight, left eye is looking towards that side. If the boy who came to see the bride has got that, what will happen? देखो बेटा भाग्यलक्ष्मी को देखो बोले तो वो गजलक्ष्मी के जैसे दिखाएगा, एक आई इधर देख रहे, एक आई उधर देख रहे. Diplopia will come. Immediately, what is our natural reflex mechanism? That abducting eye, to overcome diplopia, will quickly go into nystagmus. So define what is this condition called? Internuclear ophthalmoplegia is the name given. So what does it happen? There is a adductor lag in one eye and the abducting eye will go into nystagmus. And which side MLF lesion you call it as? The side where adductor lag is there, that side MLF lesion is the name which is being given. This is horizontal gaze story. Then we look at the people from top to bottom. The new person when we meet, उनका level क्या है, हमारा level क्या है, हम उसके level के ऊपर है या नीचे है. ऊपर है तो उसको insult कर सकते, नीचे है तो भाग जा सकते. So that is if the enemy is stronger, run away. If he is weaker, chase him. For our vertical gaze, where is the center located? Typically in the midbrain, you have tectum and tegmentum. Tectum is the roof, tegmentum is a floor. This is the place where in the midbrain you have the center for vertical gaze. In supranuclear palsy, people lose the ability of vertical gaze. If you don't know how to look down, what will happen when you are walking? You will tend to have fall. इसलिए every Parkinsonism patient that comes to your OP, you should ask the history, whether that person is having any history of frequent falls. That is what you need to basically ask for. Now what predisposes to Alzheimer's, doctor? Alzheimer's disease, Down's low education status, female sex, but not smoking. Tell me two great people who suffered Alzheimer's. One was a president, other was a prime minister. Margaret Thatcher. Have you seen the movie? Iron Lady. Oh, you should see some nice movies that inspire you, doctor. Then Ronald Reagan also forgot that he was the president of America. Nancy Reagan was helping him to walk slowly on the beach. When he was having Alzheimer's, he has totally forgotten. Nancy is the most loving wife Ronald ever had of all his wives. Right there. So, and he is also the best guy, I think, possibly out of all her husbands. I don't know whether she was multi-married. Recheck that. Then what is the most common site for hypertensive hemorrhage, doctor? Putamen. Putamen, internal capsule, cerebellum are the three locations where bleed occur. What are the things you use to decrease intracranial pressure? Mannitol, steroid, hyperventilation. You go to the neurosurgical intensive care units, they will be ambuing the patients. Why? Ambuing will basically purge out the CO2. Decreasing CO2 is a way for vasodilating and bringing down the intracranial tension. Broca's versus Wernicke's. What is the difference? Wernicke's is called fluent aphasia. A Wernicke's is problem in the comprehension area in the brain. Broca's is the motor area of the speech in the frontal lobe. Wernicke is in the temporal lobe. A Wernicke guy doesn't know to comprehend. He won't understand what he is talking or what you are talking. So, whatever he talks will be voluminous speech. Neologisms will be there. Blah, 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 blah. He will be talking. You won't understand what he is talking. He too don't understand what you are talking. Broca's will be is a breaking away speech. Doctor, he'll be saying, if I teach another couple of hours, I'll also become that, with complete vocal cord edema. But he understands Broca's. So be careful. Don't stand on the side of a Broca's aphasia patient thinking that he doesn't know. Hey, my bet is that this guy has got the MCA stroke, man, and that too lenticulostriate branches. Shall we bet? Oh, I won the bet, man. Let's have a party today evening. Beer or what type of beer you like to have? If you say no, he'll be thinking, you bloody fellow, you are learning on me. A lot of times neurology betting will happen. Neurology is like mathematics. After clinical examination, you will bet that possibly this is the diagnosis. But all that betting can occur in the conference room, not on the side of the bed. Wernicke guy is not like that. He won't be depressed, Wernicke's guy. If a stroke is there, Wernicke's aphasia is there. Old man, his son and daughter-in-law will be fighting how to get the property, who will take more and who will take less. Wernicke will not feel bad because he doesn't understand what they are fighting. But Broca's will understand. So be sure. So that is the point, doctor. So please review that. Lateral medullary syndrome of Wellenberg. There is no hemiplegia. It is a lateral medulla. Lateral medulla you are having medulla vagus, cranial motor nucleus. So dysphagia. Already spinothalamic tract crossed anesthesia contralaterally. And the sympathetic system descends from the hypothalamus and passes through lateral medulla. So Horner syndrome will be there. That is what you need to basically understand. So what is the normal mitral valve diameter, doctor? Some of you are going to be cardiologists. It is normally 4 to 6 centimeters square. If there is a rupture cardiac tendinae, what do you get? You get a cooing seagull quality murmur is what need to be remembered. This is the last question we will discuss for today's evening. Slowly we will increase the number of questions discussed. I think next week AIMS is there. You are all writing? AIMS MD exam. Please do write. On Tuesday we will have a discussion on the paper. AIMS paper. After that there is a JIPMER next Sunday. After that we will also have a JIPMER paper discussion on Tuesday or Wednesday. So please do come down. So you keep writing all entrances, DNB, all of you apply. Not that you will do DNB. अगर DNB भी पास नहीं हो सके तो आप स्टेट MD एंट्रेंस क्रैक करने का ख्वाब देख रहे तो that is too much. If you don't know how to get onto the steps of your first floor, you are thinking of going onto the top of the Everest. So for that, please take DNB. You should clear DNB. If you clear DNB, I can give it in writing that you will also clear state MD entrance. If at all it is there. State or NEET, whatever. So in severe aortic stenosis, what will be there? There will be S4. What is meant by S4? Why do you get S4? S4 is a sign of non-compliance of the left ventricle. Whenever the ventricle is undergoing diastole from atrium, first 1/3 occur because of the pressure difference between atrium and ventricle. Because atrium got filled with the blood, it is fully pregnant with the blood. The moment the valve opens, the blood will run. Second 1/3 of the flow from atrium to ventricle will occur because atrium is at higher level than ventricle, and Newton said, what is the Newton's law? Gravity pulls it down. Last 1/3 of the ventricular diastole, atrium actually contracts and pushes the blood into ventricle. If there is a aortic stenosis, then that ventricle will undergo hypertrophy. Hypertrophied ventricle is non-elastic, and atrium has to use more pressure to push the blood into ventricle, and that is the reason it will make that sound, diastolic sound, which is called S4, fourth heart sound. Why do you listen S3, third heart sound? It is also a diastolic sound. You will hear it whenever the LV fails, you listen S3. Suppose if it is a failed ventricle, what will it do? At the time of systole, 5 liters blood is there, doctor. Only 3 liters it pumped, 2 liters remained inside it at the end of systole because the failed ventricle. Into this, after systole, when the diastole begins, when the blood jumps in the first 1/3, it is jumping into a pool of blood, and that makes the splashing sound, which is typically called S3. S3 is a early diastolic sound, which is due to the jumping of the blood into a pool of stagnant blood in cases of the LV failure, where the LV failed to push the blood in the last diastolic. S4 is a late diastolic sound during the last 1/3 of ventricular diastole, when the atrium contracts and pushes the blood into a stiff non-elastic ventricle. So aortic stenosis will have S4, but never S3. Which one? Mitral stenosis. Aortic stenosis will typically have S4 initially. The moment LV fails, it will lead to S3. But pure MS only will have S4, not even S4. It will never have S3. That is the rule. You need to remember. So thanks for the patient listening, doctor.